Hello, everyone. Welcome to the third session of the Mini Medical School, a focus on global health organized by the University of Minnesota Center for Global Health and Social Responsibility and the Office of Academic Clinical Affairs. My name is Shaili Prasad, the Executive Director for the Center for Global Health and Social Responsibility, and your guide throughout these Mini Medical School sessions. We are excited to have you here today, and we look forward to navigating you through our third topic in the series. This one is about global health research, the importance of global collaborations to battle global threats. Today's session will start with a brief overview of the landscape of global health research at the University of Minnesota, followed by a moderated session with some fabulous University of Minnesota global health researchers, and a question and answer session to wrap things up. This session is being recorded and will be available to you for review tomorrow at our Canvas site. I hope you've had a chance to dig into some of the resources on the Mini Medical School Canvas site for additional information in this and our other Mini Medical School sessions. Please note this is the third of 3 sessions. You can find more information at the website that is mentioned on this slide, z.umn.edu/MMS Global Health, for all the information about the prior sessions and this session. Research is a key tenet in the University of Minnesota's overall mission. As a research university, we aim to generate and preserve knowledge, understanding, and creativity by conducting high-quality research, scholarship, and artistic activity that benefit our students, scholars, and communities across the state, across our country, and actually around the world. Given the importance of research to the mission of this university, our faculty invest a large amount of time and energy in proposing and securing funding for the research activities. So let's start by seeing how well you're acquainted with the research landscape at the University of Minnesota. So we're going to start with a couple of poll questions. The first one, in the past year, how many grants do you think were awarded to University of Minnesota researchers? Go ahead and click your answers. All right. The correct answer is 5,220, answer C. There were 5,220 individual awards made to University of Minnesota researchers just in the past year, a total of $876 million. The University of Minnesota is ranked number 9 among public research institutions in research and development. The next question. Next slide, please. Of those, how many do you think had an international component? Again, choose one of the 4 answers. The answer to that was answer B. 260 individual awards for international projects were made to University of Minnesota researchers in the past year, just short of 5% of all funded awards. That seems like a small footprint in the overall mission of the university. The university obviously has a significant global footprint in research with active projects in many countries around the world. Though some of the work may feel really remote or obscure from your life, the impact of that research is actually felt in your own backyards and by communities around the world. Some of our panelists today will share with you their work, their partnerships, and how research informs health outcomes in all communities. Our center, the Center for Global Health and Social Responsibility, has a unique role in advancing global health research at the university. We function as a catalyst for new research, partly because global health research sometimes presents unique challenges, and our center is trying our best to decrease those challenges and figure out innovative partnerships and initiatives to reduce those barriers. For example, we offer what we call seed grants. These prioritize new partnerships and collaborations and are meant to get a new project started that impact health policy or outcomes in one of our partner countries. And as you know, the name suggests, we hope that these grow into something larger with a strong potential to be scaled up, either for global application or further research pursuits. We're also very active in research training. We are home to various training programs for young researchers, both from the US and partner countries. And what I'm really excited about is the mentorship that we arrange for through either University of Minnesota faculty or our international collaborators. Our young researchers develop skills to become more independent researchers that way, and hopefully have a long career in research. Our center also provides consulting, project management, and support for researchers to help them navigate the complexity of international research studies, similar to what we do for educational programs and capacity building projects. Our center is also leading the charge in shaping the vision for what we would call socially responsible research partnership globally. We support our faculty who espouse our values, and these include ensuring that the research is relevant in the local context. One of the criticisms sometimes is that research can be extractive. We want to make sure that the research is applicable in the local context. We're also very big on equitable partnerships. And this might include shared leadership, shared authorship with our international co-investigators, and also that these partnerships are committed to long-term goals, sustainable partnerships with institutions or co-investigators. I'm particularly excited to introduce you to our panelists today because they espouse a lot of these activities that we've been talking about. And today I'd like to bring in our panelists. They come from a broad range of disciplines. They work in very diverse settings around the world and have various degrees of expertise and experience working in global settings. I'm sure you will get to know more about the various aspects of global health research listening to them. I'm particularly excited to talk to this group. If you have any questions to our panelists or to me, please type them in the Q&A box that you see in the bottom of your screen, and I will post it to the panelists. Let me start by welcoming Dr. David Bower. Dr. Bower has been a friend of our center and a leader in our academic community in global health research and training. He has helped create and grow a pipeline of research training for students across the health sciences, and he has made sure that the pipeline is accessible to his partners in other countries, particularly in Uganda. He's been an important advocate for supporting researchers at our partner institutions in Uganda and a mentor to young researchers at the University of Minnesota and partner institutions. Dr. Bower, can you tell us a little bit more about yourself and your work in global health research particularly?
Hi, welcome. So I'm David Bower. I'm a professor of medicine, and I've been at the university for about 20 years now. Seems like a long time, but I've been on faculty for 13 years, since 2007, and I've worked a lot on looking at infections of the brain and meningitis, so infection around the brain. And primarily I've worked in Africa just because it's so much more common there than in the US, and I've worked predominantly in people with HIV infection.
Thank you. In all your experience, was there a particular moment when you felt like, yes, this is my moment to start building more partnerships?
Yeah, I think, the first time I visited Uganda was, I arrived on December 31st, 2005. And shortly thereafter, I went on ward rounds. I went around in the hospital seeing patients with one of my colleagues. And the first patient I saw had meningitis. The second patient had meningitis. The third patient had meningitis. The fourth patient had meningitis. And when you looked at all of these people on the hospital ward who had HIV infection and advanced stage AIDS, tons of them had meningitis, had advanced infection of the brain, and no one was really doing anything about it. And they were all going to die. And that was kind of my aha moment of like, someone should do something about this. And perhaps that someone should be me.
And I've seen how that has grown since then. Thank you for that. Next, Dr. Kumi Smith. Dr. Smith is a superstar in the making. She's a faculty at our School of Public Health. She received one of her seed grants for her research in China in 2019 and has worked with our project coordinator based in Nanning, China, Winqing Fei. Dr. Smith, can you tell us a little more about yourself and your work in global health research?
Sure. Thanks for having me. So I'm an infectious disease epidemiologist, and I work mostly on HIV and other sexually transmitted infections. I was a China scholar before I was a public health person, so my heart has always been close to China. since then, I've really focused a lot on how HIV and sexually transmitted infections make living a normal, healthy sex life really hard for certain groups, especially for sexual minority men, female sex workers, and others. So I work a lot with mostly public partners, so researchers who work at local and regional and national health departments to try to tackle these problems.
Thank you. And was there a particular moment when you felt like this is my career, this is my aha moment?
It's more peripheral to me, but yeah, I did have an aha moment when it's hard to be a scholar of STDs and China and not know about the really interesting role that China plays in the history of syphilis. There was a long period of time when almost all STDs were eliminated from China, including syphilis. And it was because there was huge crackdowns on sex work and extramarital partnerships. And so through really strict social control, China almost completely got rid of syphilis, which has never happened. And then when the economy opened up again in the early 80s, it came surging back way, way more aggressively than anyone would have imagined. And a part of the reason that people think this might have happened is because the population lost herd immunity, which I think a lot of people may have been hearing about through COVID. But it just means if enough of the population already has the disease or is immune to it, it can no longer spread. And so what happened in China is that syphilis stopped spreading and everyone became susceptible again. So it resurged with a vengeance. And now, unfortunately, there's a lot more syphilis in China than before. And it's created an unfortunate public health outcome, but one where I saw that partnership between, in this case, US and Chinese partners has created a really great opportunity for some of the really innovative basic science that's been happening here in the US to go to China and work with a lot of the clinical expertise that folks there have been building up because of this resurgence. And so there's a really exciting partnership to look at basic science that could lead to a syphilis vaccine. And syphilis is a really high morbidity disease if left untreated. It's a really awful disease. So this is a case where I think the unique strengths of each country and each sort of scientific community is really mutually beneficial.
Thank you. Thank you for that. Next, Dr. George Ahmandi Paul. Dr. Ahmandi was a Fogarty Global Health Fellow through our center in 2017-2018. And he conducted research in epidemiology of bovine tuberculosis in the Masai Mara ecosystem in Kenya. I usually say that I don't want to be in a panel with Dr. Ahmandi because his stories are always so much more exciting than mine. I talk about diarrheal diseases, he talks about lions, you know. So Dr. Ahmandi, can you tell us a little more about yourself and your work in global health research?
Thank you. I'm a wildlife veterinarian by training. And then I happened upon One Health or human diseases from animals generally. And I basically started work as a chimpanzee veterinarian, so working with non-human primates. And as part of this, I was supposed to take care of them and work with them. So I've worked for the government, and then I was seconded to a conservancy which has both livestock and wildlife together. And so at that particular moment, I started working more on the chimps, but also on the livestock and generally the wildlife and trying to manage the different diseases. And that led me a little bit more into the human side as a way of interacting.
Thank you. And I know you have been big into connecting with people beyond your particular discipline. Was there a particular time when you felt that, yes, I need to do this?
Yeah, so at a very young age, just from veterinary school, I think I was like 22 or 23 years old. As a head veterinarian, and there was a nurse aide within the wildlife park. We call it a conservancy. And what used to happen is, after a couple of seasons, certain things were very clear. One was, whenever the grass was long, and this is a slightly short, long story. Whenever the grass was long, the human beings would complain of fever. And the fevers will come after they have had tick bites. So the young ticks, they're called nymphs, they'll have tick bites. And that is just after the rainy season. And then during the dry season, there will be an explosion of gastrointestinal diseases. And it took some time to start thinking about what is really happening, where things are just kind of mixing up. And what we ended up realizing is there is febrile diseases that are being transmitted by ticks, but also there are gastrointestinal parasites that are coming from baboons when they drink water from the common reservoir. And because that water is no longer treated, it gets into the house with everything in it. And over time, they grow into it. And it became interesting because that's the time we started kind of talking to the human medics, talking to people with the CDC in Kenya, and thinking about researchers, because that's the time we opened up to research to try and find easier ways in which we can both understand what's happening to the humans and also try to prevent diseases without necessarily messing up the interface between humans and animals, because that's an important one for the ecosystem.
Absolutely. Thank you for that. Dr. Montserrat Torre-Morel is at our veterinary school and works with our colleagues at the Center for Animal Health and Food Safety. And we're thrilled to connect with her, and hopefully this will lead to more partnerships in the future. Dr. Torre-Morel, can you please tell us a little bit more about your work in global health research?
Yes, thank you very much for having me today. It's certainly a pleasure to be here with all of you. So I'm a professor at the College of Veterinary Medicine and I'm a veterinarian by training. So I'm interested in the area of infectious diseases and in particular in pigs. So I like to study influenza and some of these diseases that pigs have. I have a bit of an unconventional academic career, meaning that I came to the university 10 years ago, but before that I was actually in the industry. So I worked for a genetics company and I had responsibilities for that company for the health program. And that was a global company. So, but back then I felt very interested on going back to the university and set my own path when it came down to research and try to share the things that I had learned in the field back to the students. That's what attracted me to get back to the university. And since then, I've enjoyed it every minute. So, and maybe my aha moment, so I will just go ahead and answer the question for some of these, you know, when we think in terms of diseases and in pigs, diseases don't have borders, right? I mean, they move with the animals. And in the US, actually in 2013, as an industry, we had a new virus introduction caused by a virus that's called porcine epidemic diarrhea virus. And actually, interestingly enough, it's a coronavirus. And it's also the source, we think, based on the genetic investigations, it also came from China, although it did not originate in China. I mean, this virus has been around for many more years than that, but the US was naive for many years. So it was an aha moment that even though we had kept the virus at bay for many, many years, all of a sudden, in some way, somehow was introduced, and it was very, very devastating to the industry. But it was just an eye-opener for us at the university from the research point of view or in the industry, how susceptible we were to some of these diseases and how unprepared we were to respond to some of these diseases, even though we had work to get ready. So a lot of planning, we thought we were pretty good. But then you have one of these situations and then you realize that maybe, you don't have all the answers and you have to continue working at it. So that was important for us, recognizing that what happened then, and in some way an eye-opener for get better and get ready for the next one. So next disease one. So
thank you for that. I really appreciate that. I do like the fact that we have 4 fabulous researchers here. They're all connected to infectious diseases in one way or the other, and considering something very important that's happening in the midst of all of us, I think it's very pertinent that we have their viewpoints here. I'd like now to transition to a little more depth in the work that they've done, particularly more particulars of the research that they've done, and also if there are specific insights that they've gleaned after the many years of research that they've done. Dr. Bo, I'm going to start with you first. Can you tell us a little more about the specifics of the research you've done?
Thank you, Shiley. I think I can. Let me share my slides here. So as I mentioned, I've really sort of focused on conducting meningitis research in Africa, so call it sort of the Joseph Conrad of going up to the source of the Nile in Uganda. And a little bit about just who I am. So I originally grew up in Indianapolis, went to IU for med school, and I've been at the U for about 20 years now, first doing a residency, sort of postgraduate residency training in internal medicine and pediatrics, and then in infectious diseases. And so I've been on faculty since 2007 and was assistant professor, associate professor, now a full professor since last year. And I work in Uganda, and so for those that are not super familiar with geography in Africa, that's sort of the map of Africa. And I've worked elsewhere in Ethiopia and Tanzania and South Africa as well, and Liberia during the Ebola outbreak a couple of years ago. But our bread and butter has been in Uganda. And this really started back for me in 2005. It really predates that. And my mentor, who's another professor, he went there first in February of 2003. And at the time, this is a picture of the medical school building. There were no HIV medicines, there was no HIV clinic, but there was tons of HIV happening in Africa, and there was a lot of interest in HIV care. And Uganda was one of the sort of the forefront sort of leaders in HIV care, and they were interested in it, they weren't ignoring the problem. And so my mentor, you can pick him out, you can take a guess on which one he might be in this picture. But he went on this HIV training program in 2003 and went back again a second time. So they basically teach a bunch of African physicians how to take care of HIV, HIV medicine, basically. And along the way, he sort of would do hospital rounds at the hospital. Here's a picture of the hospital, which is across the way from the clinic. And we basically formed this partnership with the Infectious Disease Institute in Kampala. And really, it's about partnerships. And so we developed really this partnership with Andrew Kambugu there on the left and David Maya on the right. And this partnership really has been ongoing since, since day one of my arrival in 2005, and it really has been built over the last 15 years. And this is sort of just a random picture of the hospital wards. So lots of patients sort of fit as close together as you can, people on the floor, on beds, et cetera, and doing hospital rounds. And so a lot of illness, a lot of suffering, but also a lot of opportunities to make progress. And so why did I focus on meningitis? So I mentioned sort of infection around the brain, and why Cryptococcus? So Cryptococcus is a fungus. You've never heard of this fungus, but it's probably the second most common cause of AIDS-related deaths globally. And when I went to medical school, I learned about the meningitis belt, which is sort of this belt in right south of the Sahara Desert, where there's bacterial meningitis, and so meningococcus, for which there's a vaccine. And so through medical school, we always heard about, there's this meningitis belt in Africa, and it's about bacterial meningitis. And so over the last really decade and a half, there's been a number of vaccines that have been rolled out for bacterial meningitis. And so for kids, they get the Prevnar pneumococcal vaccine, and now there's a meningococcal vaccine as well, and another meningococcal vaccine before kids go off to college. And the vaccine is highly effective. So in the meningitis belt in Africa, there's been like a 99% reduction in bacterial meningitis based on rolling out vaccination campaigns. And so as you notice, Uganda there on the sort of the East Africa there, it's below the meningitis belt. And so even though you think about Africa and meningitis, they don't really see much bacterial meningitis. They see some, certainly, but not vast amounts. So if you can see this, that when before we got there in 2001 and 2003, when we looked at people with cryptococcal meningitis, which is this HIV-related fungal meningitis that occurs in AIDS patients, the mortality rate was over 50% by 2 weeks. And so just a highly deadly disease where people were just dying in the hospital wards. And once HIV therapy was available, and sort of when you think about PEPFAR and Global Fund, they got rolled out around 2004, 2005. The typical time when people start HIV therapy after hospitalization, like these patients weren't even surviving that long to even start HIV therapy to have a long-term survival. And so when we went there, we wanted to look at a number of different things, but fundamentally this was the problem of like, wow, there's a lot of mortality, and so how do we fix that? And so when you look at how common this is across a number of countries in Uganda and South Africa, Malawi, Zimbabwe, Zambia, Cryptococcal meningitis is the #1 cause of meningitis. So for a disease you've never heard of, it kills a lot of people. And overall, the estimate is it kills about 15% of AIDS-related deaths globally. And Uganda is just super common. So among the people in the hospital, about 2/3 of people who get to the hospital who get a spinal tap, a lumbar puncture where we sample their cerebral spinal fluid, they have Cryptococcus. And so it's just incredibly common disease. So what do I do nowadays? And so basically there's probably kind of 3 critical things that I do. And so I sort of did this, a few years ago, sort of just really, launched into, clinical and translational research and took the plunge. This is a picture from Jinja on the Nile River in Uganda. And, I fundamentally try to answer 3 questions. And the first one is really how best to diagnose meningitis. And so in a resource limited area, when there's a limited amount of funds, how do you diagnose the most amount of people for the least amount of money? And at present, since I have to pay for that diagnosis, there's a limited pot of money, and so it's really sort of how to really help that diagnosis. The second question is really why do people die of meningitis? And then the third question of how do we prevent those deaths? And so while you would think #1 is pretty straightforward, #3 is kind of straightforward, #2 is really kind of tough, and it actually is much more complicated than I would have ever imagined. And the more I know about it, the less I actually know about it. And so when I think about sort of diagnosis, treatment, and prevention, we've really kind of done a number of different studies, and here's a summary slide here. I'm looking at diagnostics. And so a lot of the diagnostics we've done there have actually been then FDA approved in the US. And so we did the initial field trials in Uganda, just because there's a ton of meningitis there. And we were able to do these field trials fairly quickly and able to collect the data well and provide it back to the companies, and they're able to get FDA approval. And so those tests are actually able to be used not only overseas, but also in the US. And so what we do abroad not only benefits the locals who we're helping provide care there, but also in the US, it for things that ordinarily one could not do easily, we're able to rapidly get data such that those assays can be approved. And so a number of those have been related to meningitis or Cryptococcus or tuberculosis or just other sort of forms of meningitis overall. The second is treatment. And so we've looked at a number of issues with treatment on timing of when to start HIV therapy and Cryptococcal meningitis. We've looked at a lot of supportive care of how to really deliver care wisely. And so some of the best things we've done are like give potassium to people or give IV fluids. And so kind of standardizing the supportive care that we give to people to offset drug side effects. And then nowadays, in the last few years, starting sort of last year and this year, we've started a number of new trials looking at sort of new antifungal medicines and new medicine or new sort of treatment strategies for tuberculosis or TB. And so those are kind of exciting because we've sort of built up this platform, this research infrastructure in collaboration with our Ugandan colleagues. We're able to really be able to test therapies. And so while the predominant burden of disease is in Africa, still those diseases occur in the US, but they're just more sporadic where it'd be very hard to study them in the US because for Cryptococcus, at our university hospital, we may see, 1 or 2, patient, I shouldn't say 1 or 2, like a patient, every month or every other month. So, a handful per year versus in Uganda, we see someone like every day. And so just the burden of disease is much higher there. And so it's easier to do a research study. And then the last point I would mention is prevention, where we're looking at sort of doing screening and doing sort of prophylaxis and preventive therapy and sort of how to identify disease early on and prevent disease. And so, the saying that an ounce of prevention is worth a pound of cure is very true. And so if we can pick up people early on, that it's much easier to treat. And so when we've done screening studies where we've just screened everyone that's come into clinic with a low CD4 count and advanced AIDS who have HIV, in Uganda, about 9% of people have evidence of cryptococcal infection in their blood. And so it's a super common thing, even if they don't have symptoms. And so if you don't do anything, those people will progress to develop disease and develop meningitis and die, versus if you just give them a common antifungal like fluconazole, which is very inexpensive, they're able to survive and do quite well. And so looking at sort of, moving things upstream to utilize prevention. And so that's kind of some of the key things that we do. And a lot of what we do is totally in partnership. And so this is a picture of our team from last year. It's all pre-COVID, everyone's smiling. And so you can probably pick out the Ugandans versus the Minnesotans. But along the way there in the crowd, you can't, there's people from Kansas, from California, from the UK and London and elsewhere, and South Africa. And so a variety of people from all over the world, they really have come together to work on this. And it's been a nice partnership that's been built up over 15 years. And just some of the names here, both at the University of Minnesota as well as in Uganda and Kampala and in Mbarara and in Cape Town and South Africa and elsewhere. So sort of a great team. So that's kind of the thumbnail sketch of what I do.
Thank you, Dr. Bower. I'm particularly thrilled that some of the people you mentioned have been mentors for a lot of our other students from the University of Minnesota and other Ugandan universities. So I appreciate all the work you've done there. Next, I'd like to bring in Dr. Kumi Smith. Dr. Smith, can you give us a little more detail about your work and insights while you're doing all this work? Can't hear you. No, sorry. How about I come back to you for in a second, okay? We'll try and get the technical fix sorted out. George, Dr. Ahmandi, could you please give us a little more detail about your work?
Yeah, can you hear me?
Yes, please.
Okay. So my work started a little bit by accident years ago, but then formally started around 2017. So years ago, that's around 2009, I was sent to go treat an elephant. And then we got stuck in a rainy season. So when I went to the community, this is a pastoralist community. When I went to the community to ask for some help, I noticed they were drinking raw milk, mixing with raw blood from cattle. And coming from a home where my mother was a nurse, I was a little bit aware, plus being a veterinarian, I was kind of intrigued in terms of, for most of this other aspect, we know of tuberculosis, which is a disease caused by a bacterium. But then we also have what is known as zoonotic tuberculosis, which is the tuberculosis that originates from animals. And you can get this from cattle, you can get this from deer, you can get this from goats. It's a different type, but sometimes it's the same. Tuberculosis in human beings generally is caused by a group of organisms that basically live in different animals. And we have one main type that is caused by that is common in human populations. In 2017, I was one of the lucky people to get a fellowship, a one-year fellowship from the Center for Global Health and Social Responsibility through the Fogat International Center that is at the National Institute of Health. And this allowed me to go back into this community in Kenya to try and spend time and understand whether zoonotic tuberculosis, this is TB from animals, is actually present, and if it's present, what leads to it. Now, the fellowship was important in that it gave me the leeway to expand the question a little bit, and I'll explain. Most of the people in the pastoral populations tend to live life in close contact with animals and humans and wildlife as well. We've seen, for instance, in the US, where sometimes based on the zip code you live in, we can predict certain things. We can predict the achievement of a child. We can predict things like obesity. We can predict, even at the current moment, we can think about how in certain places COVID is affecting more people than in other places. Basically, we are a product of our environment, and we are affected and we affect our environment. Those factors that lead to disease or may expose you or predispose somebody to disease, collectively, they are called social determinants of health. I was interested in, as a pastoralist population, they are mobile, so they move their livestock from one end of the ecosystem to another to go find a grazing land. In this ecosystem, there is what is known as a national park. It's called the Masai Mara National Park, famous for the wildebeest migration. And I was interested in, with the wildebeest migration and the cattle moving to the national park, how does that affect, one, the animals, but also two, the human beings? Because the human beings are also congregating, because most pastoral population, considering that this is a very dry area, they tend to follow their familial ties. So if somebody's married from somewhere, or a cousin moved somewhere, or an uncle lives somewhere, you may tend to use their houses. They're called manyatas. But then they congregate in there, and as part of the congregation, there's also consumption of raw milk, sometimes consumption of raw or undercooked meat, including kidney, the livers. And these are places that sometimes you find the TB lodged in. So if you're eating it raw, you're most likely going to get the disease. Why did I start by mentioning the social determinants? For me, it was important because they live in this environment, they're exposed in this environment, and we don't have a lot of report of zoonotic tuberculosis in Kenya. And when I started looking at the data from that particular county, I started realizing they aggregate the data at the county level. So it looks like there's some high level of TB, but not differentiated into the different types. So we collected some questionnaire data to try and understand where do you move, do you eat raw food, do you have TB? Because the local hospitals there do use basically staining. So you give a sputum sample in the morning and they stain this, and based on whether the bacterium is in the sputum or not, they classify you as either TB positive or negative, and then you start treatment. Now, the challenge here is zoonotic tuberculosis is resistant to some of the first-line drugs. So if we are not really differentiating and it's resistant to the drugs we are using, we may end up classifying that as drug-resistant tuberculosis. Second part of it is, if I'm drinking water from streams, from watering ponds without boiling, and wildlife and livestock also drinking that water, I may also potentially get what is known as the soil-borne mycobacteria. So I may end up with what is called non-tuberculous mycobacteria, and some of these also don't respond to treatment or may be misclassified as multi-drug resistant tuberculosis. So collecting data on how the community lives, how they utilize the ecosystem, how they utilize the sources of their food, and correlating that with the diagnosis, we started realizing that even without separating into the different types of TB, we realized, number one, markets. So where do you buy or sell your cattle? Have you received bride price, and from which? So houses that had a higher level of receiving bride price, which may also be correlated to they have more relatives in different places, had a higher likelihood of having a TB case in the household. The second thing that came up more highly was the frequency with which you drink raw milk, and specifically cattle milk was a concern in that it predisposed you more likely to have TB in your household. On the contrary, drinking goat milk was negatively associated with drinking cow milk. So those who drank goat milk didn't really drink, those who drank goat milk didn't really drink cow milk, but also even those who drank raw milk and drank it always from cattle, if they drank goat milk, it was seen to be protective. So this led us to start questioning, okay, what is really happening? Are we actually seeing, because all the things point towards livestock associated factors driving TB in the ecosystem? So I went to the local hospitals, 3 local hospitals, through the county government, and tried to get samples, sputum samples from suspected TB patients. We didn't culture them. So what we did was PCR, which is basically like you see in COVID, is a test that gives you the DNA. For bacteria here, we get the DNA. And what I ended up with was pretty stunning. We expected to find the human version of TB. We did find that. But also we found 9% of the cases were what is known as Mycobacterium bovis, which is the TB from cattle. But we found 19% to be Mycobacterium capre, which is tuberculosis originating from goats or caprines. So this kind of takes us back to thinking about how do we, in terms of controlling diseases, how do we involve culture? And here we bring in the concept of One Health, which basically tries to integrate the health of the human, the animals, and the shared environment. While at the same time, one of the lack of progress, especially from the One Health perspective, in my view, is we haven't really considered culture or social cultural practices as part of the lived experiences that need to be considered. So we keep on saying, oh, overcrowding in houses, drinking raw milk and everything. That is fine. But in terms of thinking about the control, culture is very important. And I'll just draw an analogy. Bovine tuberculosis is not common in the US, but in 2006, Minnesota, the cattle were diagnosed with bovine tuberculosis. In Michigan, an adult male was diagnosed as having Mycobacterium bovis, which is zoonotic tuberculosis. He had not traveled. He had not been in contact with someone with TB, but he was a hunter. So in other words, he did catch that from animals. Now, why are these important? Some of these things are important because for us to develop diagnostics that are able to discriminate between the different types of diseases, here tuberculosis, just as David has shown, that sometimes working in places that the disease is prevalent and is common does give us a chance to quickly turn around some of these research questions, but also try to conduct in-depth research that allow us to reflect a little bit more on what does it mean to live in an environment? How does that affect you? And how can we use your environment and your behavior in that environment? This is the same thing we hear with put on a mask, wash your hands. So basically behavior can influence exposure to disease, but also behavior can be modified to mitigate against disease. So just to kind of close in, the challenge with tuberculosis is a third of the world has it, the human TB. We don't really have a good estimation. The World Health Organization estimates it at around 140,000 globally. 45% of that is assumed to be in Africa for the zoonotic tuberculosis. We haven't really worked towards controlling the main form of TB, but also controlling the zoonotic form of TB. And this is important, especially in the world we live in now, where you can travel from one end to the other. Diseases do emerge. We are having an emergence of multi-drug resistant tuberculosis. So the shared research, both from the US, but also from the African perspective, does allow us to address this issue from multiple angles.
Thank you, George. I really appreciate it. This is particularly concerning because the stories from India where people who are on multi-drug resistant TB treatment have not been getting it consistently because of the COVID challenge. And we don't know what kind of an explosion of new cases we're going to have from there. Dr. Smith, if I can bring you back again, can you give us a little more detail about your work and the insights from it, please?
Am I still audible?
Yes,
okay. Fantastic. I'll just quickly share mostly pictures to go along with what I've been working on. So I mentioned earlier that I am interested in making sexual health care accessible to all kinds of people. And one of the reasons that's an important thing for us to look at is because when it comes to getting help for any health issues surrounding sex, there's a lot of social stigma. People are embarrassed to get care for a sexually transmitted infection. Certain people don't feel welcome at healthcare clinics, no matter why they're presenting. So that could be someone who has HIV. It could be someone who has a history of substance use and other types of populations who just don't have good experiences in healthcare settings. So something I'm working on in China is to figure out how we can address and mitigate the stigma faced by people living with HIV and sexual minority men. So these are men who identify as gay or bisexual. And what we're trying to do is figure out why are they facing so much stigma when they try to get any kind of sexual health care, and what can we do about it? I'm showing you this slide because one of the biggest challenges with stigma is how to measure it. So in a typical encounter at a clinic, if we have a situation where a doctor mistreats a patient, there's kind of two ways we could learn about that. We could either talk to the doctor, who in this case would be the enactor of stigma, or we could talk to the victim of stigma, who's this blue figure who we might also describe as the target. Problem is, if you talk to the doctor and you say, hey, how do you treat your patients with HIV? It's unlikely that the doctor is going to say, yeah, I treat them all pretty terribly. They have a lot of reasons to maybe massage the truth and not be totally forthcoming about their discomfort with treating patients with HIV. And we could also talk to the patients themselves, and we certainly do this, but there are challenges here too. A lot of stigma questions ask people, were you targeted or discriminated because of your sexual orientation or because of your HIV status? And the fact is when you're just one person and you have a lot of different identities, it's going to be difficult for you to know exactly why you might have been treated a certain way. There's also a lot of what we call information asymmetry in medicine. That means the doctor has many, many years above you of really specialized medical training. And so they have a lot of extra information that you probably don't about what kind of treatment you should be getting, what kind of medical course is best for you. So you may perceive them as withholding a certain treatment or giving you the wrong kind of clinical care, but you can't really know for sure because after all, we as patients are most often not the doctors. So we're working on a project where we're saying, well, what if we could get a neutral third observer to observe these encounters in clinics? And in this situation, that would be the green person. But the problem with a neutral third observer is that it's just really socially awkward. If you put a random person, like say a member of our study team, to sit inside clinics and stare at the doctor and the patient just trying to have a conversation, everyone feels uneasy. And certainly the doctor would not be expected to act as they normally would if not observed. In fact, the fact that doctors change their behaviors when they're being observed is so commonly understood that it actually has a special name called the Hawthorne Effect. So the group that I'm working with, we've actually decided to try a different technique where we say, what if we take that neutral third observer and put them in the place of the patient? And so they're still the patient in the scenario, but now they're actually a patient who's observing what the doctor is doing. So our technique for doing that is called standardized patients. You may have heard of this as a way to train medical students. It's very common in the West, and it's becoming increasingly common in China. A standardized patient is just a trained actor who will go in and present a standardized case to a doctor and then sort of observe what that doctor or what that medical student does. And often at the end, we'll provide them with feedback. In our case, our standardized patients are actually trained members from the local MSM or men who have sex with men community. And what they're doing is going into doctors and they're each time saying the same thing. However, and this slide's a little messed up, my apologies. What we're trying to do is to see, does the HIV status of a patient or does the sexual orientation of a patient affect the quality of care that they might receive? So what we've done here is, this is just showing you a 2x2 table. So if you look on the left column and the right column, that shows you our standardized patients who would go to a doctor, and in one situation, they would say, I have HIV. In the other, they would say, I don't have HIV. And if you look at the rows, this would be the difference between saying, I am a man who has sex with other men, or I am not, so otherwise a straight man. And you can see if you randomly vary, you can actually have 4 different scenarios. One where a standardized patient shows up and says he is an HIV positive MSM, an HIV negative MSM, an HIV positive person who identifies as straight, and one who has none of these identities. And what we're doing is we're sending in these standardized patients to present as one of these 4 different scenarios, and we randomly vary it, except that each time every other feature of their case presentation is identical. So this allows us to contrast and compare across these 4 scenarios and to actually quantify, is the quality of care different when people have any one of these 3 identities, which is sexual orientation, HIV status, or the combination of the 2. So we're doing this study in Guangzhou, which is the capital of Guangdong province, very close to Hong Kong. It's a very idyllic and beautiful city, very hot in the summer too. And this is where it is situated on the map. For us, it's really important that we do this work in partnership with the community. And here's a picture of us full on dim sum with the Zhitong LGBT group, which is a LGBT advocacy and health promotion group working in Guangdong. I've been working with this group for about 8 years. And working with them, we have actually recruited a number of young men who identify as gay or bisexual to come and work with us to be standardized patients. So here they are sitting in our hospital. This is actually pre-COVID. So I believe the doctors are masked really just for effect. But this is a training session where we're training the standardized patients basically how to be actors and how to show up in a clinic and present a realistic case of someone who is seeking care, in our case, for a suspected case of syphilis. And what they have to do is try to convince the doctors that they are a real patient. And then at the same time, they have to observe what the doctor says and reacts and does. After each visit is finished, they then report back to us and tell us what they observed and what happened. And so this is another picture of one of our partners working with a volunteer doctor. And what we do is we send them out into the field to go into clinics and to randomly vary their presented cases. And our study has been slowed down by COVID, but we do expect to have results hopefully by the end of the year, showing us a baseline understanding of exactly what role does something like HIV status or sexual orientation play in deteriorating the quality of care that patients experience in healthcare settings. So that's just I'm hoping that stopped the broadcast.
Yes.
Yep. That's a brief introduction. Yep, sure.
Thank you, Dr. Smith. I can see applications of similar models, not just for STDs, but pretty much all conditions that we are dealing with. So I really appreciate that. Dr. Torre-Morel, if I can bring you in, can you share a little bit about your work, please, and some insight about the work that you've done, from the work that you've done?
Yes, sorry about that. I had still mute. I trust you can see my screen. So what I wanted to talk about, the work that not just myself, but the group, several of us at the University of Minnesota are doing in the swine group to help the industry to prepare for this disease that's called African swine fever. So, and I want to tell you a bit more about the disease and the impact of the disease, and then go from there. Okay. So even before I do that, okay, just to help you, I knew the audience was probably more familiar from the human perspective or the medical perspective. So I thought maybe I would just have to start just to give you a bit of background about the swine industry in the US and why we care about getting ready for some of these diseases. I don't know how much the audience is familiar with it, but I just wanted to say that food animal production, and in this case, the swine industry, is certainly an economic engine for the country. Across the US, it's certainly a lot of pork producers, 60,000 are reported in the US, and they contribute significantly to job creation and as well to the economy, okay? So, and one of the things is that the industry relies a lot in exports. So a lot of the pigs or pork that is produced in the US is exported. And until recently, pork was the most consumed meat in the world. I believe now poultry is just slightly ahead for various reasons. But so it's very significant source of protein globally, okay? And at the same time, the industry is very efficient in the US, has come a long way on how animals are raised and then are processed and so on. So it's in the best interest to keep an industry like that afloat, just because it's one of the most sustainable ones. And if we think in terms of Minnesota, Minnesota as a state, it's the second state in the US where there is more pigs raised, okay, with about 9 million pigs in Minnesota. So it's very, very important. And as I mentioned before, it depends both of national and international markets. But one of the things, besides all these things, one of the things that we need to be cognizant, and it's important for food animals in general, is that the diseases that can affect them, it's one of the major threats to, in this case, US animal agriculture. So the diseases that affect the productivity of the animals, Dr. Ahmandi mentioned that a bit before with the TB cases, but the diseases that affect the productivity of the animals, or other diseases that have implications for trade, basically meaning that you cannot buy or sell, in this case, pork to other countries, are very important and significant. I mentioned before that in 2014, actually the disease was introduced in 2013 in the US, this porcine epidemic diarrhea. And one of the things that happened, because it caused very high mortality, fortunately did not affect human health. So that's very important to recognize. But one of the things that this coronavirus does is actually kill the baby piglets, okay? So, and as a result, the industry was affected significantly, and even the consumer could feel the impact of that disease because the price of pork went up significantly, okay? So I just wanted to provide this background just to illustrate the importance of diseases in our domestic animals, and in this case, specifically in food animals, and pigs being one of the species, okay? So I just wanted to have that. So, but what I wanted to talk is about this African swine fever, which, as the name indicates, it's endemic in Asia, in the wild pigs, warthogs in Africa, and it's been around for many years, and it's been controlled and eradicated from many places, but we've seen an increase in Eastern Europe, and in particular, it's endemic in some countries in the wild pig population. But one of the things that happened is in 2018, actually, Asia, China in particular, had this disease introduced into China. So, and I will speak a bit more of that in the next slide. But before I go there, I want to say that this is one of the worst diseases that affects the pigs, okay? It doesn't affect people, so that's the good thing in this case, but there are no vaccines. And even though there's been a lot of research, and it continues to be research, at least until now, there are no vaccines available. And it produces, as you can see in some of the images here, very high mortality. Unfortunately, the US is free of this virus, the African swine fever virus, okay? But if the disease was to get into the US, that would have huge immediate implications for the producers in the US, but also for the markets globally. There would be an immediate stop of the exports, which the US, when it comes down to pork, exports 26% of all the pork produced. So it would be very significant. The other thing that it would happen is that the pigs themselves, to control the disease, they would put very strong regional control programs, which would be very disrupting to the markets and the way how the pigs are raised. And we would have to get to a point in which we would have to eliminate the disease. And unfortunately, because there is no vaccine, one of the things that has to be done is actually to euthanize the pigs and eliminate them that way. So it would be very devastating. And this is some other images. It's a hemorrhagic disease and very devastating. And that's not, there is a list of diseases that would fall in this category. It's not only African swine fever. There are other diseases, but again, would be very, very devastating at many levels. So even though it's an old disease, I was saying, and over the years, again, it's been eradicated from many countries, we've seen this reemergence of this virus, and it's been accentuated in the sense, and we feel like the risk globally has been increased significantly because in 2018, there was this major outbreak in China, okay? And basically about 25% of the pigs worldwide disappear. Actually, China is the country that has the most pigs. About 50% of the pigs produced worldwide are in China. Okay, and then if you make the math, so pretty much about 40%, some estimates, we don't really know exactly how many, but it was a very significant proportion that actually disappear. But at the same time, because of the situation in that I mentioned, the other coronavirus that was introduced in the US in 2013, there is this increased alert in the US and all other major pork producer countries that we feel like this could happen anytime, that you could, the disease. And this is our virus. This is a extremely hardy virus, very high survival in the environment. It can also survive for a long period of time in the carcass of the dead animals, or in another important source is actually in the meat itself, even in processed meat or in cured meat. So one of the things like that in the US to get ready or to prevent the introduction, you may notice in some of the airports there is, or we hope, the increase in inspections on the passengers that come from some of these countries that are affected because a lot of people bring still products, meat products, into the US to share with the family and so on. And many of those products could be infected with this virus. And this virus is very hardy, so it could still have active virus that if it make it to a live animal in the US, then would be very devastating, potentially very devastating. So what are we doing to help in some way to get ready and to help to control it when it's a disease that we don't have it? So we cannot work in the lab ourselves unless it's a BSL-3 or as a BSL-4 lab. So we cannot do a lot of the work on the epidemiology in the US because we don't have it, which is a good thing. But at the same time, we want to get ready for it in case, or we also wanna be helping some of our partners in the countries like China and Vietnam and in other places where they have this disease, because we have expertise on epidemiology and in disease elimination, eradication of the diseases and in biosecurity, that then we feel like we could help them to control it in their own, backyard, sort of. So our group, it's been very active, working in, in the countries I just mentioned, and also working in collaboration with the US, USDA, US government, establish some of those collaborations. And many of those collaborations have to do with helping advance diagnostics, figuring out what's the best sample type or how to monitor large populations at a low cost. There is efforts on vaccine development. That's not an area in which us personally, we get involved. We get more involved on the area of understanding transmission in particular, and then how to prevent that transmission and strategies for elimination. And one strategy that we have a lot of experience from other diseases is how can you actually help control the disease in those farms without actually having to eliminate the animals or only eliminating the affected ones. But we work, those are big populations, and the traditional methods is that you would have to get rid of the complete population, not just of the affected individuals. So we work on how to identify those individuals, and it's not so straightforward either. And then how do you do it that then you don't put the rest of the animals at risk? So we work with partners in other countries. We also work with producers here in the US to help them get ready for that disease or others through what we call the secure pork supply plans. And some of my colleagues are involved on doing risk assessments. And then, a very key part for us is also the training of the students as part of the process, because then these students can go and work and get deployed. So we are very active from that perspective. And this is my last slide that maybe that can lead us as well into a discussion that I want to mention is that some of these global diseases certainly need global approaches, but to bring local solutions. And sometimes we don't always recognize that. And I think I wanted to say that because we have to always be ready for the next one. And we have to often go and work, as the colleagues here in this webinar today mentioned, you have to go to those places to learn or to try or some of the best treatments so we can be ready here if we need to. So with that, thank you.
Thank you, Dr. Tara Morel. That was really wonderful. I'm going to get us started on the question and answer session. And starting with a question for you, Dr. Ahmandi. Has it been difficult to get communities and organizations to understand the significance of animal health? And how do you justify your work to the public?
Thanks. That's a really, really nice question. 2 or 3 key points on that. In societies where they live on less than $2, $3 a day, livestock becomes a way in which they can escape or they can become their livelihood. The cattle are the assets, the goat and the sheep are basically the current accounts. They can sell that for $30, $40 and use that going on. The challenge has been to put animal health on the same pedestal as human health in such a way that people understand that they are tied and they depend on each other. So a lot of research work has shown that when the health of the animal is poor, the health of the family is also poor. And some really nice work from Kenya has also shown that in houses where, for instance, they spent more on keeping the animals alive, they had stunting in children. And so that the first part of that question in how I'm trying to answer it is, it's not really straightforward for people to understand that actually the human health and animal health are tied together. The second part of it is human health does affect animal health sometimes directly. This can be tied both from diseases like rabies, but also if you think about the topic I was talking about, like zoonotic tuberculosis, public health information in terms of can you keep your animals healthy to prevent things like brucellosis, which is another bacteria that comes from milk, or can you boil or cook food? That message can be tied both from the animal health perspective, but also from the human health perspective. In other words, if you take care of sanitation and health within the family, you're more likely to take care of other things like E. coli, Escherichia coli, which is another gastrointestinal disease, and other things like Campylobacter and other things. The challenge is tying that information for people to understand that animal health is a public health. I think drawing that connection sometimes is a challenge. But in terms of the public, what I've seen that has worked, at least from my perspective, is tailoring the information to behavior. So when I started out, I started by doing postmortems on wildebeest that die in the Masai Mara River. And I got a lot of photos for tuberculosis in the kidneys. So what I did was I would show them that, hey, do you guys know kidney? They will say, yes. I tell them this is from a wildebeest and this is TB. And they're like, oh, we do see that and we cut it off. And I'm like, well, even if you cut it off, sometimes a piece of it remains and you get tuberculosis. And you see that information, you come back 6 months later, people start, well, they call you the TB person, but I associate that with public health information.
Right. Well, thank you, George. That's actually wonderful in terms of really practical application. Here's a question for Dr. Smith. I'm curious to know if the standardized patient ID has been used to work at racial disparities in care.
Can you hear me?
Yes.
Okay, good. That's a fantastic question. And the answer is, yeah, we're actually piloting that here in the US. I also work a little bit with opioid use disorder and access to getting treatment for it to prevent overdose from opioids. So I'm working with a few doctors in addiction medicine here in the Twin Cities. We just got a pilot grant where we're gonna ask standardized patients that we hire and train here to go in and see what is it like to get opioid treatment if you're someone who's presenting with all the signs of opioid addiction. And in the course of putting this application together, it did not take a lot of digging. I'm new to Minnesota, but I have learned that there's a lot of research showing about just how severe race disparities are here in all metrics of health, and opioid overdose mortality is no exception. So I've talked a lot to folks about why is it that someone who uses opioids is going to be at so much of a higher risk of dying from overdose if they're Black as compared to white. Native American is even higher. But we're restricting this study to the Twin Cities, and for sample size reasons, restricting it to comparisons of what it looks like when a Black presenting SP comes and asks for opioid treatment versus when a white presenting SP comes and asks for opioid treatment. There's a lot of different health areas you could look at. There's a huge amount of research about race disparities in maternal health and maternal mortality. The key barrier is, though, you need strong partnerships with whatever healthcare system you're going to be working with, because I didn't mention it before, but it is very important that you have the prior consent of doctors. We don't just spy on doctors. We tell them, we invite them to the study, they consent to it. And what we ask them is, are you cool with us sending an actor who you probably won't know is a fake patient to come and present at your clinic sometime in the next 6 months? And we sort of bank on them forgetting. And we have ways to check if they actually figure it out. And it turns out about 5% of the time, they will guess correctly that it is a fake patient. So these partnerships with local healthcare systems are really important. And the point of it is not just to expose disparities, but also to really sort of understand the underlying mechanisms. Is it lack of exposure to this group? Is it fear of getting some kind of disease from a certain group? Is it that you're intimidated by this new health issue that you're not as familiar with? Is it preconceived stereotypes? Is it implicit bias? So there's a lot of things we're trying to uncover with this tool. And the goal of that is to then use that to inform tailored trainings for doctors, and to continue to monitor health systems to make sure that any efforts we make are actually producing the results we want. Thank you for that question.
Well, thank you, Dr. Smith. I'm particularly impressed with the premise of pragmatic solutions rather than theoretical ones. Actually going and checking it out. Appreciate that. Dr. Tora Morel, here's a question directly related to the talk you gave on the swine disease. Is there a fear of the disease jumping from pig to human?
Well, I think we know that what percentage it is. A significant percentage of diseases that we know, they are zoonotic in nature, right? So that means that they jump from the animals to humans. And there are some diseases, and I will speak, let's say, an example is influenza. We share diseases, it goes actually back and forth. So there is the risk that risk it's there when we have animal populations interacting with people, that there is a possibility of jumping, of exchanging pathogens and some of those are able to replicate and produce onward transmission. And that's why it's so important to understand ecosystems where the animals are raised, or how they're raised, and how they interact with other species and in the environment, so that we can prevent some of those, or anticipate some of those risks. So
thank you, appreciate that. And also a follow-up question. I've understood that CAFO, I'm assuming
CAFOs.
this is concentrated animal feeding operations, they're environmentally unsound. Any thoughts on that?
yeah, so I think there is a lot of perceptions about, in this case, I personally don't like to call them CAFOs. To me, that that name, it's been used in a very negative way. But basically, what we are talking is populations that are raised in intensive production systems, because actually they might even be more sustainable. What I will say is that the producers are trying very hard, and in many instances, to actually raise them in a very sustainable way, and in environmentally friendly systems, and they invest to do that, so that there is no pollution or no contamination. And of course, over the years, there has been incidents, and I believe the question referred to North Carolina in particular, that there has been situations, but I think the producers are working very hard to have sustainable systems that are certainly environmentally friendly.
Thank you for that. Dr. Bower, I would like you to reflect on your changed portfolio, if you will, after COVID-19. I know you've done a significant pivot and been very productive. Can you speak a little bit about that?
Yeah, so one of the things working in Africa is our team. We have a great team of doctors and nurses and statisticians and pharmacologists and all sorts of people that work together. And, because we work on certain neglected diseases, we've got to do all the work ourselves. And so when the pandemic came about with COVID, we're used to doing what's termed investigator-initiated clinical trials, where we run the clinical trials. And so back in early March, as COVID was sort of starting to take off in the community, and it was like very obvious in early March from an infectious disease perspective, this is going to get bad. And so we're like, hey, someone should do something about this. And once again, it's like, who is that someone going to be? And it's like, well, maybe that should be us. And so we launched a series of clinical trials. And this is early March, we decided to look at hydroxychloroquine. You might have heard of the medicine since then. And as such, why did we look at this? So at the time, it was not political, but it was an available, cheap medicine that had in vitro activity. Having done tropical medicine, I was, familiar with it from treating malaria and other sort of rheumatologic conditions. And so we launched a series of 3 trials. One was on post-exposure prophylaxis, looking after people were exposed to disease. And so that we ran these trials basically in March and April. That got published in early June. We looked at early treatment. So if you treated people as an outpatient with hydroxychloroquine, we also looked at zinc. And did that, improve symptoms or make people better faster? And so the answer was no. And so that got published in July. And then lastly, we looked at preventative therapy. And so could you take it as a prophylaxis before you got exposed? And so we looked at about 1,500 healthcare workers around the US and in Canada. And the answer was, if you took it sort of once or twice a week, kind of like what we do for malaria prophylaxis, once again, it did not reduce or didn't statistically reduce the incidence of clinical sort of disease. And so these were sort of a series of trials. And that got just published actually on Saturday in Clinical Infectious Diseases. And so we did sort of a series of these randomized double-blind placebo-controlled trials to try to test out, like, did this work or did it not? And so it was a randomized trial, meaning as people went into the trial, they were equally, distributed between a placebo, which we used folic acid, or the active drug. And then it was blinded, meaning they didn't know what they were going to get. And as the investigator, I didn't know what they were going to get either. And so there was a pharmacist who did know what they got. But and so we basically followed them and saw what happened to prevent disease or improve infection. And so the answer was unfortunately no. But I think the positive aspect is we actually got an answer, which was nice. And but also that because of our experience in working overseas and sort of research limited areas, we were able to do this trial fairly quickly. And from sort of concept to launch was 8 days. And the trial was done within about 7 weeks. And we had submitted it to a journal by early May. So, so we were, so we sort of pivoted to COVID. And so we did some COVID stuff and sort of we did our stuff and we're sort of pivoting back to meningitis now, I guess. But that was our COVID interlude.
Well, David, I think you're being a little modest. The fact that you were able to rapidly pivot and come up with some really meaningful, answers, I think is just amazing. So appreciate all the work you and your team have done on that.
Yeah, thank you.
Here's a follow-up question to our two veterinarians. Are there any approved products that can prevent or treat COVID-19 in animals yet? I'm really curious. And the follow-up I have for that question is, we hear a lot about coronaviruses in animals. What has your experience been in that? And do you feel that as a scientific research community, we have lagged behind in addressing coronavirus in general?
I may take the second part of the question first. There are actually a lot, I don't know whether a lot, but there are several coronavirus affecting animal species, pigs. We have 3 or 4, bovine, and also in some of the domestic animals. Interestingly, actually, there's been a lot of research in coronaviruses in animals that I believe we can learn from now from the human health perspective, and not just thinking about the individual animal only, but how to vaccinate populations. There is quite a bit of research on bovine coronavirus, I was saying, and actually bovine coronavirus has a lot. It's also a beta coronavirus, which is SARS type 2 is also a beta coronavirus. So there is actually quite a bit of similarities on how you need to, at least in the cattle side of things, immunize them to be able to develop an effective immune response. So certainly there is a lot of information there that I think we can learn and share. And if anything, sometimes I feel like we don't exchange enough of that knowledge. Obviously, COVID came very quickly all of a sudden, but I think there is quite a bit of experience there that can be learned from it. And the first part of the question was?
First part was, are there any specific treatments for COVID-19 in animals?
Not that I'm aware, in the sense that in animals, we know, like, for example, there are documented cases of transmission to cats or minks, but the treatment is actually prevention in those cases, in the best, to the best of their ability. I'm sure there is a lot of trials going on that use animal models to try some of those drugs that then hopefully they get approved on the human side, but not on routine use yet.
So I don't know if I can maybe chime in a little bit here. So, a lot of it's very easy to do a lab-based study. So in a petri dish, you're looking at stuff, and so there's lots of things that have activity in a petri dish, and so generally that's the first step. And then the second step is taking it into an animal. And so there's various animal models of primates, of non-human primates, so the monkeys. There's hamsters and ferrets and things like that. And so and so those animal studies are kind of important because if they don't work in animals, it's unlikely to work in humans. And so, for instance, hydroxychloroquine does not work in animals, but remdesivir does. The monoclonal antibodies, such that President Trump got from Regeneron and Lilly and other things, those did. The vaccine studies have been tried in non-human primates before they went on into human studies, and so those are protective. And I'm trying to think of the other major compounds that are. Yeah, there's a lot of things that the animal studies are kind of usually, those are easier and quicker to do because you can challenge them, where you take an animal, you give them the medicine, and then you challenge them with coronavirus and to see if it prevents infection. And so some of the nuances of those studies are really important because, like, do you give it before, do you give it afterwards? And so some of the medicines might work before exposure, but they don't work after exposure. And so there's some nuances there. But yeah, so there are things that work in animals, but that doesn't necessarily mean they're going to work in humans, because oftentimes, like, this very idealistic, like, oh, we're going to start therapy 24 hours after infection, it doesn't really happen in the real world if you've got a multi-day turnaround time for testing.
Right. Good question. Good point. Dr. Smith, this is your final question. One is about the legal issues in undercover patients. And the second one, I think, is a more important question. Any parallels between the fight against HIV/AIDS and the quote unquote fight against COVID-19 as it relates to policymaking and public opinion?
Sure. Regarding legal challenges with the standardized patient study, we work really closely with the ethical review folks. We call them the Institutional Review Board, to make sure that our approaches are sound. We actually go above what the IRB wants us to do because we're not collecting personal health information from these doctors. We're just observing them in a clinical setting. So what we're collecting from them is not necessarily considered by health researchers to be sensitive. However, we're really sympathetic to the fact that if there is some documentation of a doctor's clinical behaviors that don't look good, that they would not appreciate us going around and sharing that. So we make sure to explain to them very carefully how we plan to analyze this data, the precautions we take not to identify them or their clinic. And of course, this is all for learning purposes. So we are working closely with doctors to make sure that they're on board for the training, that they feel that this is also an important public health issue and that they would like to close gaps in their own capacity. So these are the ways in which we're making sure that they can feel comfortable. And again, participation is always completely voluntary. We don't go and observe doctors who don't want any part of this study. Regarding parallels with HIV and COVID, this has been talked about a lot, and I think it's a very interesting observation to make. There's been a lot of conversation about just how, in the absence of our knowledge about how to control this epidemic, and in this case, how there's been a vacuum of consistent and clear public health guidance from the top. A lot of us have ended up, unfortunately, resorting to finger pointing and judging each other for our public behaviors. This is really reminiscent of what happened early on during the AIDS epidemic, when it was mostly gay white men who were dying of HIV. That was the most visible sort of type of person. Excuse me. That was the most visible type of person who was falling victim to AIDS. And so a lot of judgment was passed on this community saying, well, it's your sexual lifestyle, it's your inhibitions and other sort of moral judgments on these folks that were then tied to having the disease. This is happening now with COVID. And so there's a lot of folks who say that, you know, it's the scientific approach of what we actually know about the agent, not the behaviors, and how what we know about the pathogen itself and how that can inform the public health practices we can all follow. I think that's one lesson we're taking away. A second one is that stigmatizing behaviors that are very human, whether that's having sex or socializing with loved ones or just being out and about in the world, stigmatizing these things does not make people change their behaviors. In fact, it will probably backfire. Yeah. So I think learning and remembering our public health messaging lessons is very valuable right now.
I thank you for that. And I think this is an important lesson for all of us. I really appreciate the work you've done, not just in your professional career, but also to communicate this. And I think as scientists, as researchers, we have a huge role to play in that science communication. And also connecting with each other, saying that we're all in this together. And we can't really, divide this and decide that we go our own way. So all the work that you've done, and it's sort of probably easier to demonstrate this in infectious diseases, particularly when you look at species jumping behaviors. So thank you all. I really appreciate this. I would like to really ask our audience members to go to our Canvas site and look into the details that we have uploaded into the Canvas site for all the resources that you can use. Feel free to ask questions there or follow-up questions there if you want to. I'd also like to leave you with this message of our, this is the last of our mini medical school. However, we have a very important presentation coming up next week It's our annual Peterson lecture, and Dr. Paul Quee and Dr. Phil Peterson were both infectious disease doctors. And this lecture has been named after them. And this year we decided to do it a little different. It's going to be about the political determinants of health. And we feel this is very important. Dr. Ahmandi brought up the point about social determinants of health. And we strongly believe that the social determinants of health are directly connected to the policy and the politics that determine them. So we have two experts, Dr. Ilana Kickbush from the WHO and the University of Geneva, talking about the political determinants of health in the global arena, and Dr. Daniel Dawes from the Morehouse School of Medicine in Atlanta, who wrote the book on the political determinants of health. It's not coincidental that this talk is 8 days before the elections. And then Dr. Laura Bloomberg from our public policy school, the dean of our Humphrey School of Public Policy, will join me in a panel discussion. I hope to see you folks there. And again, thank you, panelists. You've been great. Appreciate all of you joining me today.